Hello, I'm Chris Kowdley. On behalf of CME Outfitters, I would like to welcome you and thank you for joining us for today's CMEO briefcase entitled Throwing a Curveball at Hepatitis B Serological Tests, Interpreting Results to Guide Next Steps. Today's program is supported by an educational grant from Gilead Sciences. I'm the director of the Liver Institute Northwest and clinical professor at Elson S. Floyd College of Medicine at Washington State University in Seattle, Washington. Case-based learning is a great way to bring to life some of the challenges and curveballs our patients may throw at us. Today, we're going to meet Samuel. He is a 54-year-old man with chronic hepatitis B, known for at least 14 years, who immigrated from Sierra Leone 8 years ago. He has been maintained on tenofovir alafenamide or TAF with stably suppressed hepatitis B for the past 3 years. Now, Samuel presents today with abdominal pain, back pain, vomiting, and fatigue for the past 7 days. So let's see what's going on with Samuel. Hello, Samuel. Nice to see you today. How are you feeling? It looks like you've had a rough couple of days. Please tell me what's been going on.
Hello, Dr. Kowdley. I've been feeling very bad for the past week. I don't know if it's a bad case of the flu or what, but I've been vomiting for about a week, and I'm pretty wiped out and can barely get out of bed. By the way, thanks for doing this as a televisit. I wasn't really feeling up to driving over. Anyway, in addition to the vomiting, I'm having a lot of pain in my stomach that sometimes it has me doubled over. Other times the pain is in my back.
I'm really sorry to hear that. Let's dig a little deeper and try to figure out what's going on. Have you had a COVID test recently?
I've actually been vaccinated for about 2 months now.
Oh, that's great to hear. Now let's go over your medications. You've been on TAF for your hepatitis B, and you've been virally suppressed for about 3 years. Have you been taking your medication regularly and without fail?
Yes, I promise you, I'm really, really good about that, taking my Hep B medication just like I'm supposed to.
Any different vitamins, over-the-counter medications, any supplements or herbal products that you might have been taking?
No vitamins or anything. Now, I have been taking Tylenol, which is helping me with the pain.
And how much Tylenol have you actually been taking?
I actually take 2 extra strength tablets, and I haven't gone over that because I know that it's not good for my liver. And to be honest, it really hasn't helped much anyway.
Okay, I'd like you to go to the lab to have some blood drawn. We're going to check your hepatitis B because you have that always in the background. We always need to keep an eye on your liver enzymes because you have a chronic liver condition. And then I'm also going to order a few other tests. If you can head over there today, we should have the results back tomorrow. So let's plan on checking in late in the day tomorrow.
All right, thanks. I'll head over there now.
Let's now take a look at the results of the serologic tests obtained on the patient. His hemoglobin was 14, hematocrit was 43%, so those were normal. His platelet count is 200,000, that was normal. His hepatitis B surface antigen came back positive, as you would expect. Hepatitis B viral DNA was 50 IUs per mil, consistent with chronic suppression from tenofovir alafenamide. His aminotransferases, however, are markedly elevated with an ALT of 520 and an AST of 340. His total bilirubin is also elevated at 2.2 milligrams per deciliter. Alkaline phosphatase is slightly above normal. His kidney function is normal with a creatinine of 1.1, and his albumin is in fact a little bit low at 3.4. So we now come to an audience response question. If Samuel has been adherent to his TAF, what might be the likely cause of the acute infection? Hi, Samuel. Thanks for jumping on a televisit.
No problem. Anything in the blood work that gives you an idea as to what's going on?
Yeah, there's definitely something going on related to your hepatitis B, or something else that may have caused an acute viral infection. Your liver enzymes are definitely elevated.
That's not good.
Well, it appears you may have been exposed to another virus or a drug or medication that may be causing problems. Let's start with the possible drug interactions or new medications or supplements. I know we talked about this before, but I just want to ask you again, have you begun any other medications or taking any herbal supplements lately?
No, nothing new.
Is there a chance you may have been exposed to another infectious disease like hepatitis C, HIV, or CMV, or some other virus, either through exposure casually or through sexual contact?
Well, I don't mean to get personal, but I do have reasons to believe that my partner may not be monogamous, and I have no idea if she has been using a condom.
Well, that's not good for you or your partner, but it does give us some information that we need to follow up on. Sorry, but I'm going to need to have you head back to the lab for another blood draw. I want to expand the testing to include HIV, hepatitis A, hepatitis C, and hepatitis D or Delta. I know it's concerning, but we need to know what's going on and try not to worry too much or jump to conclusions.
Okay, you're right. First, let's find out what's going on. Thanks very much, Dr. Kowdley. I'll talk to you tomorrow.
Now, our learning objective here is to implement routine screening protocols for hepatitis B in a primary care setting to derive guideline-directed care and to improve the detection of hepatitis D infection. So as we've seen with Samuel, an acute hepatitis B flare can be the result of a number of exposures and factors. We're going to focus on patients who may be co-infected or super-infected with hepatitis D or Delta in the setting of chronic hepatitis B or acute hepatitis B infection. So as I mentioned, our learning objective is to implement routine screening protocols for hepatitis B in a primary care setting and to improve the detection of hepatitis D using guideline-directed care. So hepatitis Delta is a serious co-infection of hepatitis B that is estimated to affect 48 to 72 million people with chronic hepatitis B worldwide. And co-infection with HBV and HDV is most prevalent in Central Asia, Eastern Europe, Central Latin America, and West and Central Africa. HDV requires hepatitis B for replication, and thus hepatitis Delta infection only occurs in the presence of hepatitis B infection. Now, the mode of transmission of HDV or hepatitis Delta is similar to hepatitis B and includes sex with an infected partner, injection drug use that involves sharing needles, syringes, or drug preparation equipment, or other paraphernalia, birth to an infected mother, which is quite rare, contact with blood from or other open sores of an infected person, needle stick or exposure to sharp instruments, such as in an iatrogenic or medical environment, or sharing items that could potentially transmit the virus, such as razors or toothbrushes, with an infected person. Now, the symptoms of hepatitis D present much like those of other viral hepatitis infections and may include fever, fatigue, anorexia or loss of appetite, nausea, vomiting, abdominal pain, dark urine, clay-colored bowel movements, joint pain, or jaundice. Most symptoms typically occur 3 to 7 weeks after the initial infection. So now let's go back to Samuel. If testing to determine if Samuel has hepatitis Delta, what additional serologic tests would we order? So hepatitis Delta can either be present as a co-infection with hepatitis B, meaning the patient is exposed to both viruses at the same time, resulting in a more severe clinical outcome than with hepatitis B infection alone, or superinfection, where hepatitis delta infects a patient who already has chronic hepatitis B infection. Co-infection results in an acute HBV and HDV infection, and as I mentioned, may result in a more severe presentation than we see with HBV alone. This co-infection resembles a classic acute hepatitis B infection, except that a biphasic course of ALT may sometimes be seen several weeks apart, as shown on the slide. Now, most patients do recover during the acute co-infection, and only 5% of patients will go on to develop chronic infection, which is a persistence of infection beyond 6 months. Remember, hepatitis B virus needs to be present and actively replicating for hepatitis delta to be able to co or superinfect a patient with hepatitis B. Now, what about superinfection? Individuals who are chronic carriers or chronically infected with HBsAg, meaning they have chronic hepatitis B, may develop a superinfection with hepatitis delta. This may present as an acute severe hepatitis from a different cause. It may also be mistaken as an acute flare of the chronic hepatitis B. The clinical course is possibly more severe, and 90% may progress to chronic HDV infection in the setting of chronic HBV infection, resulting in more severe morbidity and complications. And the course of infection is shown on the graph. As you can see, you have evidence of hepatitis B chronicity with a surface antigen that's positive and stays positive. And then you have HDV superinfection that occurs on top of the hepatitis B chronic infection. So let's go back to the serologic tests that would be appropriate to order to determine if Samuel has HDV. The correct answer is B. The tests you will want to order are hepatitis delta antigen, most specific test at 92%. You would like to order the total hepatitis delta antibody that incorporates both the IgM, which is generally reflects acute infection, but may be present in some cases of chronic infection, and the IgG, which is usually a marker of chronic infection. The IgM is the most sensitive with an 87% rate of detection, but least specific with 42%. Now, directly measuring HDV RNA is a way to detect viremia. And remember, hepatitis delta is an RNA virus, whereas hepatitis B is a DNA virus. So this test for HDV RNA detects viremia in 93% of patients with chronic hepatitis B. Remember that measuring serum hepatitis delta antigen by immunoblot is the most specific test for measuring hepatitis delta infection. The most sensitive test is the hepatitis D or anti-hepatitis delta immunoglobulin M or IgM, but it lacks specificity. And of course, the PCR assay detects virus in 93% of patients by measuring hepatitis delta RNA. Now, what about treatment for hepatitis D? Currently, there are no FDA-approved therapies for HDV infection. However, high-dose interferon alpha-2A has shown a survival benefit when dosed at 9 million international units 3 times a week. Another alternative interferon is pegylated interferon alpha, and this is administered at a dose of 1.5 micrograms per kilogram or a fixed dose of 180 micrograms subcutaneously once a week. An undetectable HDV RNA at the end of treatment was seen in 19 to 57% of patients, with a sustained response in 17 to 43% at 6 months of follow-up after treatment was completed. However, sustained viral clearance persists in 28% at 1 year. Patients with higher HBV DNA load seem to respond faster than those with HDV viremia only in the absence of circulating or replicating hepatitis B viral DNA. tolerance and outcomes do not appear to be improved with addition of ribavirin, adefovir, or entecavir. There's good news on the horizon. There are a number of emerging treatments for hepatitis D, and these include an entry inhibitor, also known as bulevirtide. This is approved in Europe. A phase 3 FDA breakthrough therapy designation has been provided, and it's designated as an FDA orphan drug. Another option is lonafrenib, which is a prenylation inhibitor. And this compound is also in a phase 3 FDA breakthrough designation status and designated as an orphan drug and given fast track by the FDA. Lambda interferon was studied as an immune modulator or an immune response stimulator and is phase 3 ready with FDA breakthrough therapy designation and orphan drug and fast track designation. And there are other drugs such as REP2139, which is a surface antigen inhibitor in phase 2, and ezetimibe, an NTCB inhibitor in phase 2. So of these therapies, the treatments for hepatitis D that are in late stages of development include bulevirtide, which when combined with pegylated interferon alpha-2A or TDF, led to HDV viral suppression. A third of patients taking bulevirtide with TDF maintained an undetectable HDV viral load after discontinuing therapy, and the treatment was generally well tolerated. Lonafrenib reduced viral load and can be safely boosted with ritonavir to allow for higher and more effective doses to be administered. This has been studied with and without interferon lambda and interferon alpha-2A. The gastrointestinal side effects that may accompany this therapy are generally considered to be acceptable. Two forms of interferon have been used, lambda and pegylated interferon. The phase 2 LIFT study was an open label study of 26 adult patients with chronic HDV treated with lambda interferon, 180 micrograms weekly, in combination with lonafrenib, 50 milligrams, and ritonavir boosting at 100 milligrams BID for 24 weeks with a 24-week follow-up. 95% of patients achieved a greater than 2 log decline in HDV RNA at 24 weeks, with 53% achieving undetectable HDV RNA. And this therapy was generally well tolerated. So let's summarize our discussion with our SMART goals, which are specific, measurable, attainable, relevant, and timely. That is what I hope you will take from this presentation that can be directly applicable to your practice today. Recognize the presentation of an acute hepatitis flare and factors that may link the acute infection to hepatitis delta. Implement appropriate serologic testing to uncover the source of the HBV flare. While there are no FDA-approved treatments for hepatitis delta, become familiar with the safety and efficacy data related to agents in late stages of development. Today's CMEO BriefCase is the first in a series of case-based activities, and the Liver Disease Hub has these activities and many others on hepatitis B, hepatitis C, NASH, and much more. And I strongly encourage you to visit the site and take advantage of the offerings for education. CME Outfitters also has an HBV patient education hub with a number of excellent resources to share with your patients, many translated into Vietnamese, traditional Chinese, simplified Chinese, Hmong, or Korean. Thank you so much for joining me today. Please stay safe, and thank you again for providing the best care for your patients.